Welcome to Science Force, where science comes alive. Welcome everyone to a brand new explainer. Today, we're exploring a condition that is quietly hiding within the very engine of our bodies. We are decoding hypertrophic cardiomyopathy, or HCM. It's a brilliant journey we're taking today, perfectly tailored whether you're a curious mind wanting to understand human health or a dedicated medical student needing those precise clinical facts. So let's dive right in. Here's our roadmap for today. First, what is HCM? Then, the pathophysiology of HCM. Next, symptoms and deadly complications. After that, diagnosing the thickened heart. And finally, treatments and patient prognosis. Section 1. What is HCM? And why exactly do we refer to it as the hidden flaw? Globally, about 1 in 200 to 500 individuals are affected by this condition. That is a truly staggering number, isn't it? It makes it one of the most common inherited cardiac disorders in the world. And the scariest part? So many people walking around with this condition have absolutely no idea it's even there. So let's break down exactly what this means. Hypertrophic cardiomyopathy is a chronic and usually inherited heart disease. The word hypertrophic literally just means abnormally thick, and cardiomyopathy means a disease of the heart muscle. Essentially, the myocardium, your heart muscle, becomes excessively thick, usually right along the septum, which is the muscular wall separating the left and right ventricles. Because it thickens without an obvious cause, like long-standing high blood pressure, for example, the muscle becomes incredibly stiff. It entirely loses its vital elasticity. Now, interestingly, up to 65% of these cases are genetically inherited. Specifically, it's passed down in what we call an autosomal dominant manner. What that means for a family is if one parent carries the mutated gene, a child has a 50% chance of inheriting this exact disease. The remaining 35%, well, those come from unknown or other causes. This brings us to a really vital clinical distinction, especially for the medical students tuning in. We have true HCM, which is genetic and driven by mutations in the sarcomere genes, but we also have non-genetic mimics. Conditions like an athlete's heart from highly intense physical training, long-standing hypertension, or even Fabry disease can also cause the heart muscle to thicken up. But unlike true HCM, these mimics have entirely different underlying root causes. All right, moving on to Section 2, the pathophysiology of HCM. Let's zoom in from the microscopic cells to the macro functioning of the whole heart. Let's see how this cellular chaos builds step by step. It all starts with Step 1, a mutation in the sarcomere genes. This leads to Step 2, where the heart muscle cells actually enlarge and fall into total disarray, eventually being replaced by stiff, fibrous tissue. Which brings us to Step 3, the massive thickening of the ventricular wall. Because that wall is now so thick and stiff, we hit Step 4, severely reduced ventricular filling when the heart tries to relax. And ultimately, this can trigger Step 5, where the thickened muscle physically blocks blood from leaving the heart, a critical condition we call LVOT obstruction. To put it simply, the sarcomere is the heart's basic contractile engine. A mutation here is essentially a DNA typo. So instead of neatly aligned muscle fibers working together, this genetic typo builds a chaotic, totally disorganized mess. In clinical medicine, we refer to this hallmark feature as myocyte disarray. Because of this chaotic cellular structure, the disease generally manifests in two main ways. On one side, we have hypertrophic obstructive cardiomyopathy, or HOCM, and on the other, non-obstructive HCM. HOCM is the most common form. It features a physical blockage, that LVOT obstruction we just mentioned. This means symptoms worsen significantly during exercise, and doctors can actually hear a distinct heart murmur. Now, the non-obstructive form doesn't have this physical blockage, but the stiff muscle still struggles heavily to relax and fill with blood. Let's turn now to Section 3, Symptoms and Deadly Complications. We really need to understand how these structural flaws cause real-world, highly dangerous problems. While some patients can live their lives completely symptom-free, others experience a very dangerous domino effect of cascading complications. It starts mechanically. Because the stiff ventricle can't fill properly, pressure backs up into the lungs, causing breathlessness or dyspnea and severe fatigue. Plus, that thickened, chaotic muscle demands way more oxygen than the blood can actually supply, leading to chest pain or angina. The disorganized cellular structure disrupts electrical pathways, causing palpitations and arrhythmias, and during exercise, blood pressure can drop so drastically that it causes syncope, which is fainting. In severe cases, this cascade progresses to heart failure, strokes from blood clots, and tragically sudden cardiac death, which is incredibly devastating when it strikes young, otherwise perfectly healthy athletes. To really visualize this mechanical failure, imagine a kinked garden hose. That is exactly how left ventricular outflow tract obstruction acts. It kinks the flow. Adding to this, the anterior leaflet of the mitral valve actually gets dragged toward the thickened septum during a heartbeat, a phenomenon known as systolic anterior motion, or SAM. This physically blocks the exit, forcing the heart to generate massive, exhausting pressure just to pump blood out to the rest of your body. So how do cardiologists find this hidden flaw? That brings us to Section 4, Diagnosing the Thickened Heart. Medical professionals use a very specific diagnostic toolkit for this. It begins quite simply with the patient history and a physical exam. A doctor might hear a harsh systolic ejection murmur that actually gets louder when the patient stands up. From there, they'll use an electrocardiogram, or ECG, to spot electrical abnormalities, followed by echocardiography and cardiac MRIs to visualize the wall thickness and detect dangerous fibrosis. They will also use Holter monitors to catch intermittent arrhythmias over a 24 to 48-hour period, and crucially, genetic testing to screen the patient's family members. Now, among all these tools, echocardiography is the absolute gold standard for initial testing. An ultrasound of the heart allows the physician to visually capture the massive septal hypertrophy and literally watch that dangerous systolic anterior motion of the mitral valve happen in real time. It's a total game changer for exposing the chaotic architecture inside the heart. Moving on to our final part, Section 5, Treatments and Patient Prognosis. How do we restore the rhythm, shrink the muscle, and protect these patients? Let's explore the pharmacological solutions first. The first line of medical management is usually beta blockers, like metoprolol. These slow the heart rate down, giving that stiff ventricle more time to relax and fill properly. If those aren't tolerated, calcium channel blockers like verapamil are a brilliant alternative to help the heart relax. And more recently, we have cardiac myosin inhibitors like mavacamten, which is a newer medication that directly targets and reduces the excessive contraction of the heart muscle itself. But what happens when medications are simply not enough? We turn to surgical and interventional solutions. First is a septal myectomy, an open heart surgery where the surgeon physically shaves off a portion of the thickened septum. If surgery isn't suitable, they can perform an alcohol septal ablation. Think of this as a highly controlled microscopic demolition. A catheter delivers alcohol into a tiny septal artery to create a targeted infarction, shrinking that overgrown muscle over time. Finally, for those at high risk of sudden cardiac death, we use an ICD, an implantable cardioverter defibrillator. It sits right in the chest, constantly monitoring the rhythm, ready to deliver a life-saving electrical shock if things go dangerously wrong. And this brings us to a highly optimistic point. With early diagnosis, sensible lifestyle modifications like avoiding dehydration and intense competitive sports, and modern medical therapy, many patients with HCM live a completely normal or near-normal lifespan. Proper nursing management, medication adherence, and regular follow-ups yield a truly excellent prognosis. We conclude today's explainer with a very powerful thought. If you recall, 60 to 70% of these cases are inherited. The DNA typo is passed down from generation to generation. So, with genetics loading the gun, how will you protect your family's heart? Understanding your family history and seeking out genetic screening could quite literally be the difference between life and death. Thank you so much for joining me on this deep dive into the thickened heart. Stay curious, stay informed, and keep learning.
Thank you for watching Science Force.